Awesome. Good afternoon, everyone.
Hello.
Nice to see you all again. Thank you for coming back for session 2 of our Applied Communication Skills unit that we're going to be covering. So, we're going to jump straight in because we've got quite a bit to do today. As I said in our last session, we're going to be covering our case studies that we talked about in your meetings that we had prior to the sessions. But just to quickly reorientate you to the workplace, so in the event of an evacuation, we will go out, down to 6G, down 2 flights of stairs. The evacuation diagram is outside room D, and we have one up in here as well. Our area warden is Maddie and Mel today. So in the event of an evacuation, we will just follow their lead. Any safety considerations, as we're going to be doing some case studies and we'll be standing up, moving around, please be careful that you don't trip over anything. There's just something against the wall there, and these chairs do creak a little bit on the ground. So, like me, I kick my feet on them all the time and trip over. So just please be aware of this. And the bathroom's just outside. And please feel free to go if you need to go. All right. So what we're going to be covering today, we will be going and doing. I'll be doing a quick bedside handover just to demonstrate what we kind of want from you guys. Then you guys will take turns handing over your patients and we'll sit down and we'll discuss it, and that is part of one of your assessments for this unit. And so then one of them is done and the others you'll be doing in your own time, which you'll be filming and then uploading onto Blackboard. I just want to also reiterate the person receiving handover is equally you making sure that you've clarified everything and you're understanding everything you've been handed over. And don't forget that throughout your nursing career you are going to come across stuff that you don't understand, even if you've been nursing for 10 years. So never be afraid to be like, oh, what's that? I've never heard of that before, because you will find that no matter what level you are. So anything you hear that you're unsure of, just ask. Okay? And as I said before, you need to make sure we know what's going on with the patient. We don't want to call them outside work hours as well. I am not one myself to answer my phone if I see a work call coming through. I'm like, no, I'm home now. Okay, so by the end of this session, just some objectives. I just want to be able to make sure that you're able to demonstrate how to appropriately hand over a patient in a clinical setting and at the bedside. And then also explain in detail what information comes under each heading of ISABA. Okay? Because we'll have a little activity a bit later on as well. So, I'm going to reiterate what we learned about ISABA. So, what information would come under identify?
The patient's name, date,
Mm-hmm.
and how many days they've been there.
Yeah. Name. Length of stay, I'll just shorten. What else did we say?
When did that
Oh,
ID
they-
check?
The
ER.
Yeah. There was another big thing that they talked about. Pronouns. Pronouns is actually really important. So that's something that when a patient is admitted, we should be checking with them. Do you have pronouns that you want us to be following? Because we never want to get that wrong for someone, because it can be, people find it quite traumatic when they come into hospital and they misidentify what they, how they like to be addressed. And then anything else is any other identifying features as well. So what else could we say? Age, but that comes under date of birth. But sometimes you like to say, oh, 85 years old. Yeah. Situation.
Why are they on hospital?
Yeah. Why?
What procedures they've had?
Yep. So I'll just write current plan.
Yep.
Observation.
And chart, vascular obs.
Yeah. So I'm just going to write physical assessments.
Yes. Is also like if they've got a cannula in, where that is, and
Yes, definitely. Because that's something that we need to make sure that we check every shift as well, isn't it? Our PEPAS sites.
any like medical devices on them, like drains.
Yeah, anything of the drain. So if you have a patient that you're handing over at the bedside and they have got drains, anything coming out of them, that's when you should check it as well. Like if you've seen the back dressings, making sure that's on the right setting as well is really important. Because you could come along and sometimes, and it does happen, you come along and the patient's been out having a smoke, classic, and they've come back inside and jumped back into bed, left their vac machine and haven't plugged it back in again.
Yeah.
So it's off. So make sure you check your vac machines as well.
How they mobilise?
Yes, that's definitely one that will come under here.
history that's relevant.
Yeah.
Allergies. Their social life.
Yeah. Assessment? Yeah, definitely. So we said plan there, but like plan really could, like what's upcoming. So that could be one, what has occurred already. Sorry, mine, what has occurred.
Mm-hmm.
And then this is what is happening. Yeah, the plan. And anything else that you needs to be followed up with. Might say you're on in the morning and you're like, so and so, we've been flat out doing this and I haven't given them a bed wash yet. You're handing over a task. So that could also be an assessment because that's going to be part of kind of the next shift, yeah?
I noticed on this one they also just include medications, like IVIG, and like.
Yeah, so things that you notice that are, you're like, I've just noticed that the plan was to have IVABs and they haven't charted anything, so we just need to make sure we follow up on this. So yeah, so handing tasks over.
Yeah.
Yeah. Because remember, nursing is 24-hour care. And if you don't get things done in your shift, that's okay. You can hand it over because there will be someone else to take over from you.
Yeah.
And then read back and recommendations, which is just
Yeah.
the person clarifying.
Clarifying.
Yeah. So let's write clarification. Cool. So you've remembered a lot of that. Fantastic. Okay. I'm just going to now quickly hand over a patient, and so you can see what I want. I have a piece of it for myself. If I can find it. So I won't hand it to anyone in particular,
Okay.
but I'm just going to quickly hand someone over. I should have uploaded to this beforehand. Okay, Vanessa, I'm going to be handing over to you. Okay. So Vanessa, I'm going to be handing over Leonie to you. I've already checked and she's happy for us to hand over at the bedside. So we'll come in. We're going to check our emergency equipment. We're going to check her name band. So Leonie, blah blah blah, and her URM number and date of birth. So Leonie came in with necrotizing fasciitis. So she was over at Armidale Hospital for quite a long time, and then was transferred to our ICU. And she has been in hospital for about 22 days at Royal Perth. She was probably in Armidale, I think she said about a month before that. And this is when I could say, is that right? To Leonie herself.
Yeah.
Is that right? Did I get that information right? And then they could then clarify to me. Leonie likes to be called she, her for her pronouns. Leonie's had multiple washout and debridements of her wound. It is on her right leg and wraps around to the back. She's had multiple washouts, and then they have tried to cover it with a skin graft as well. So we've got a vac dressing which is sitting over the top of it. She has a falls risk. Because she is rest in bed, she hasn't got any strength in that right leg of hers. So we haven't been getting her out of bed, and it does take about 4 of us to give her pressure area care. We're doing her vital signs every 4 hours. Her most recent AD score has been a 0. She's not in too much pain aside from when we have to do the dressing changes, but thankfully because of that back dressing is on, we don't have to do it today. She is diabetic, so we have got blood sugars. The last one was 5.2, and she's on QID insulin. So I've just given her some before lunch. She's going to go through the charts and we're going to finish that as well. Got an IDC and Antilex seal. Both have been dread. There's no problems with those. She's got a pick in her right arm, and the dressing is due to be changed tomorrow. And she's also got a cannula because she has got IV antibiotics, insulin and dextrose infusion, and she frequently needs blood products because she has lost a lot of blood because of this wound. Okay. She's got allergy to penicillin, just breaks her out in a rash. Past medical history, as I said, we've got diabetes, which has been affecting this wound healing quite a lot. And she normally lives alone at home, so she doesn't have a lot of family support that can come in and give her a hand. So our social workers have been involved in her care, and they should be coming to see her this afternoon. She's got heparin, she's got TEDs, she's got calf pumps on, and then we've just got that back dressing it running at 125 milligrams of mercury, so check that.
Yeah.
So that's to come down tomorrow as well, a back dressing, so we can have a look at the wound. So if we could hand that over to night staff to make sure that they take the dressing down. And she just needs to have a repeat bloods done this afternoon as well, just so we can see what her HB signal is. It was a little low yesterday. Okay. Do you have any questions? Yeah. Okay. Are there anything that you want to contribute? Are you okay with that plan? Is there anything else that you're worried about? You can ask questions like that. Because sometimes they do have worries that we haven't quite addressed. They've been sitting and stewing over it, and they're suddenly like, oh, actually, I have a dog at home and I don't know who's looking after it. We can then try and get the social worker involved.
Yeah.
So it's just making sure, is there anything else that you're worried about? How does that sound? Make sense?
Yeah.
Okay, you look nervous. You don't need to be nervous. It's very casual, and once you have a go, as again, we'll sit down, we'll talk it through. Yeah, any questions before we jump in?
When we sit with our nurse, do you want us to go through each, like as we talk, we flip through the charts
Yeah.
as well?
So sometimes what you do, have you seen it when they do bedside handover? They take the chart with them, they don't see they were hypertensive this time, and you can just flick through as you're doing your handover.
Cool.
Yeah? Yeah, okay. So now we just need to figure out who's going to hand over to who. So Sally, you'll hand over to Vanessa. Alice, you'll hand over to Sally. Tahara, you'll hand over. Oh, that's perfect order. I didn't even do that. Vanessa, you'll hand over to Tahara. Is that right?
Okay.
Did I get it right?
Wait.
This is Sally. So no, Sally, you're handing over to, yeah. So Tahara, you're handing over to Vanessa. Sorry.
Okay.
The person whose name is at the top is who you're handing over to.
Okay.
Yeah?
Okay.
That makes sense, yeah? Does anyone want to go first?
Wait. Okay.
So you're handing over to me,
Oh,
I
yeah.
have your name, and then
Oh.
I was handing over to you.
Okay.
No, the name you have at the top is who you're handing over to. Is this your case study?
No, this is Kihara.
Sorry, I've confused myself here.
Oh,
Yeah.
Tahara will hand over to you.
Yeah, because
Yes.
this is what I have.
Vanessa will hand over to you, Tahara.
yeah.
Alice will
I'll
hand
hand
over
over
Sally.
to you.
Yes, I was right the first time around.
Yeah.
Sorry. Vanessa, Sally will hand over to you.
Okay.
Okay.
Sorry, does that make sense?
Yeah.
Okay. Does anybody want to go first?
I don't mind. I'll go first.
Okay. And just a because this is a simulated session and I couldn't get an IV pump for us, if anyone has any pumps, anything like that, just simulate it that you're checking, just so I can see. Don't forget your emergency checks as well, checking ID bands, consent.
Consent. Yes.
Yeah. Okay.
Okay.
So Alice, you're going first. So I'm going to be your patient. I'm going to sit here.
Okay.
And you guys are going to come into the room. You're going to
Oh,
stand up and do it. Yeah.
Do I bring the sheet? I don't really need it.
No, so you can have that so you can
Oh,
see
okay.
what Alice is handing over to you.
Yeah.
And if you want to write anything down, do you have a pen?
Okay.
Yeah, you can write anything down, and then that way you remember, oh yeah, I just want to clarify this because I didn't quite understand.
Okay.
Let me just
Yeah.
make sure I get the right patient. So, Alice, you have Mary Lamb.
Mary Lamb.
I tried to be fun with the names.
Oh my gosh.
Okay, this isn't just.
It'll be fine.
Okay, when you're ready.
Okay. Hello, Mary. And can I start again? You already know Okay. Cool. Hello, Mary. How are you?
Good, thank you.
We're just gonna do handover to the night shift.
Yeah.
Is that okay if we do that in front
That's
of
no
you?
problem.
So we come in. I will check your ID band.
Yeah.
Can I have a look? We have Mary Lamb, 10th of the 10th, 1940. And yeah, and then we will do our safety checks. Check, and we are fine. Okay, so this is Sally.
Hello.
And this is Mary Lamb. Her pronouns are she, her. She's been in here for 5 days and she's an 84-year-old woman who's come in from her nursing home. So she has come in for a degloving injury to the right lower leg post falling in her nursing home. And she's had a debridement and a split thickness skin graft applied yesterday. The skin graft donor site is on her left thigh, so there's a dressing there, and that's to stay intact for 10 days. And then she has a back dressing on her right leg, and that is to stay intact for 5 days. This is day 4, so it'll be coming off tomorrow. So I'll have a look at the charts because we have a table. So today Mary was an AD score of 1, just for hypertension, systolic blood pressure in the 160s. The team, her medical team, is contacting cardiology to review her antihypertensives because she's had high blood pressure for a few times now. Her neurovascular observations, this is for her right leg.
Okay.
Her pulse is feeling a bit weak, it looks pale, but she's warm to touch and just decreased movement because of the injury. Pain score 8 out of 10. On her PRN, she was charted oxycodone, which I gave about half an hour ago. And I haven't checked back with you, but how are you going for pain at the moment?
It's feeling a lot better.
Feeling a lot better?
Yeah.
Yes, she is a falls risk. She has toilet privileges, which she is a standby assist to get to her walking Zimmer frame, and then she can go to the toilet. But other than that, she's a rest in bed. And she's on an air mattress for pressure area care, and she's fine mobilising in bed, so you can turn yourself. Is that okay?
Yeah. Just need to tell me when.
Yeah, I will prompt you.
Yeah.
And then OBS 4 hourly, neurovasculars 4 hourly. She has a cannula in her right forearm. PIF is 0. It's looking fine. Do you have any pain in that area at all?
No.
So she has a past history of hypertension, which you can see in her ads. It's always been a bit high. Dementia and AF. She's got an allergy to tramadol, which I noticed is not charted on the med chart. So I'm sorry, if you could put a sticker on there and get someone to put that on there. And she lives in a nursing home. She's got good family support. Your daughter came in to visit you today, which was that nice?
Yeah, it was nice to see her.
And we didn't have a bed wash this morning or this afternoon, so maybe we can try one tonight or earlier in the morning, whatever you prefer. What else? Sorry. She has, with the medications, she refused the apixaban and the metoprolol at 8, but I checked again at 12:30 today and she had them, so I gave them then. She is for IVAVs, but they're not charted at the moment. And yes, I'll get someone to co-sign that.
Oh, okay.
Oh, okay. You didn't know that. And then it says on the handover that she's for 3 times a day heparin, but she is charted, Quexane, just once a day. So we might get that reviewed by the team, see what's going on there. Bowel's not open yesterday or today, so yeah. I don't know what to do with that. We can get that reviewed, see if we can get you some medications to loosen your stool. And so the plan, the back dressing on the right leg is to come down for tomorrow. And the team is still reviewing her antihypertensives, and she's still ongoing with the physio and OT. And she will be returning to the nursing home upon her discharge. Do you have any questions with any of the agreed upon plan?
It all sounds good to me.
And do you have any questions regarding her care?
That sounds all good.
Alright, thank you.
Thanks.
And bye.
Okay. How do you feel?
If I practice more, it would be okay. But
Yeah. So one key thing that I would say that you probably maybe would have handed over outside of the room is
Yes.
why I was refusing the medication this morning.
it does say not compliant.
Yes.
Yeah.
So I was
It
embedded this
happened.
morning refusing a bed wash.
Yes.
I have dementia, but I'm not usually this upset. I'm normally pleasantly confused and compliant, but when her daughter arrived, it became more settled, and then I started to say I had a lot of pain in my legs.
Yeah.
So that will probably be some like important information to
I
hand
was
over.
going to mention that I would do that outside the room.
Yeah,
and then
yeah, so that's the kind of stuff that you would maybe say, okay, that's a little bit more sensitive not to say that around the
Yeah.
patient. Yeah, but then it also, it's showing that you understand that family is a very good support, which you did hand over, which is great, but then it just shows that, oh yeah, while the daughter's around, it does help settle her down.
Yeah.
And it also explains why she wasn't given a bed wash this morning, is because
Yeah.
I was refusing, I didn't want to have one because I was in a lot of pain.
Yeah.
But otherwise that was really good, you were very thorough. Yeah, very no, that's good, that's good. But just so you know as well, if someone hadn't had their bowels open for a few days, what could we do?
We can give them a medication for it.
We could also have a listen as well to their abdomen as well, yeah, just to see if we can hear any bowel sounds. Because the last thing we want is to then have a patient have a small bowel obstruction.
Yeah.
Yeah. Cool. How did you feel?
Yeah, good.
You got a lot of information?
Yeah.
Yes.
I really went to questions, so I kind of got.
That's fine.
Then
Normally
she
I would
covered
say,
them.
yeah. Normally I would say wait until the end to
Yeah.
ask you questions, because more often than not they're going to cover what your question is going to be. And then there's nothing. It's really tricky when you're trying to hand over and someone keeps interrupting to ask you a
Yeah.
question. You're like, just wait, I'll get to it. Yeah.
That's really interesting about the oxycodone. I didn't know that.
Yeah. I don't know. It could be different
Okay.
policies for different hospitals, but we're just one signature on the medication chart,
But just
two
check.
signatures in the books.
Okay. That makes sense.
Yeah. Okay. Who wants to go next?
I can go.
Yes. Peter Piper. Oh my god.
Is that my knee? Following.
Okay. Let me just refresh my memory.
No, you're fine.
Okay.
Hi Peter, how are you?
Yeah, I'm alright.
Good. Just heading over to the night nurse now.
Okay.
That's all good with Vanessa. Cool. I'm just gonna check your ID band. We got Peter Piper, that's the first 1980, and your amendment, little woman. Cool. Checking all the checks, emergency, oxygen.
Yeah. So this would probably be the person who's coming on. Then
Oh,
you would
they
do the
check
check.
it.
Yeah, you would do the checks just because it's your shift now.
Okay.
And you want to make sure everything is working for
Sure.
your own knowledge. You're like, I've
Yeah.
checked this. Yeah.
Yeah. Everything's working. Cool. So that's all we can know. So yes, so we've got Peter Piper. So yeah, date of birth 1st of 1st, 1980. He was admitted today at 11:30. Came into the ward, just for little finger fracture when he had his fall. He is currently fasting for ORF, and he has consented to the procedure. I've got the preoperative checklist here. I just haven't started it. Yeah. Cool. He's not at falls risk at the moment. Independently mobility, that's really good. Observations for hourly. Let's have a look here. Yep, adds of 1 just from his blood pressure. But he is fasting at the moment for that procedure, but the team has been notified for that one. And the neurovasculars have been all good, just a pain of 5. Yeah. Cool. Sorry. Oh yeah, so the patient is on IVAB's Zephyzolam, which is a prophylactic. He does have type 2 diabetes, and he does have an allergy to micropore. What was that allergy? What, did a rash? Or?
Yeah, I just broke out in rashes and blisters.
Yeah,
on my hands, yeah.
Yeah, he's got a PIVC in his right forearm, which was put in today. We are awaiting for another one, just to put insulin dextrose infusion in. But yeah, I haven't paged for that yet.
Okay.
Sorry. Okay. And we go through. Yep. So PIVC in situ 0. His last blood glucose was 15.6, 0.1 ketones. Yeah, so before we go to surgery, class 16 just want it below 10 millimoles. Yeah. Cool. That's the intake. Having a minute because it's due tonight. So just hand it over to the night nurse. That one all good. And then I just gave the 12 o'clock paracetamol. Yeah. And these ones all good. Cool. So yeah, yeah, he's just currently fasting for procedure. We're just waiting for the second PIVC, the insulin dextrose when we go for it. Yeah, all good. Do you have any questions?
No. When am I going to theatre?
We're waiting to find out.
Oh, okay.
Yeah, sorry. We're just wanting that blood sugar to come down a bit, just because it is a bit high.
Yeah.
They want it below 10.
Okay.
So yeah,
All right. Okay.
and then we'll see what they say.
Okay.
Cool. Good.
All right. Happy?
Thank you.
Right, Vanessa, are you happy?
Yeah.
What's the plan?
Fasting for procedure and second PIVC for insulin.
Yes. So, have either of you seen any of you seen an insulin dextrose infusion?
No.
Here you have. No.
Mm.
So an insulin dextrose infusion is literally you have a bag of insulin and then a bag of dextrose running at the same time. And you know they obviously do opposite things. And that's so we have them running at the same time and then we check their blood sugar levels quite frequently. And we then can modify the rate to make sure that we can make sure we get the sugar to what we want it to be. So if you get that insulin dextrose chart out, so this could be something that you could have said, this is charted, but I'm not yet hung it up. And it's probably because you don't understand what this form is, which is totally fair. But this is your order for your insulin, but as you can see, it's not been given yet. And this is your order for your glucose, it's not been given yet. So, but you're like, we can't give it yet because we need that second cannula. Why do you think we need a second cannula? What did you say they were on prophylactically? Kevin's on them, yes. So he's on IV antibiotics and on an insulin dextrose infusion.
Oh,
And
okay.
you can't run them all at the same. Because the insulin dextrose infusion is continuous, so you wouldn't be able to stop it, put your CAF through, and then restart it. You'd need two separate ones. But the insulin and dextrose can run through the same cannula. We can put like a little adaptation on. We call it a chook swab. It's got the two lines, and so you can attach them both onto the same one.
And then when I leave the room, I'd tell her about the ETOH
Yes.
and the uncontrolled.
Yeah. Do you want to speak about that?
Oh yeah. So ETOH is just over alcohol use. So maybe get a chart for it. It's just called withdrawal signs. And also, oh yeah, the iron controlled. So he doesn't monitor his BSL or prescribe his prescribed insulin. He doesn't do it.
Do you know that hospitals have diabetic educators as well?
Yeah.
Yeah. So that could be something. Maybe we should think about getting the diabetic educator to come and speak to the patient. All right. Thanks. How'd that feel?
Yeah. I think just because like we hadn't handed over to like a patient for kind of before,
Yeah.
so it was like a weird feeling, but yeah, it's good.
Yeah.
To kind of get practice in those things and things.
Perfect. Okay. Who's next? Yeah, you're right there, Sigmund as well. Right. Who have we got? Giorgio Armani. Got it. Okay.
Do you have the other things? Like the, oh,
Hi, Giorgio Armani.
Buongiorno.
Okay. Hi, so I'm just going to give the hand over to the PMS. Is that okay?
Si.
Alice, hello.
Buongiorno.
Giorgio Armani, 15th of 12, 1972. So you are in.
Yeah.
So
And I will just do the safety check.
Perfect.
Oh, good.
so
Oh, he has fluids, does he?
yeah, he has.
Okay. So check the fluid is.
But you can do that when you get to it.
Ah.
Yeah.
Sorry. You go.
So Giorgio Armani, he admitted 2 days ago. Diagnosed with left hand fracture met with an accident with e-scooter versus a car, and then he's been fasting for a procedure, but I already filled the pre-op checklist, but I couldn't sign it here because since we need an interpreter because he's having minimal English, so we need an interpreter, and they booked it for 1 p.m. But we still didn't get to meet him. Okay. So he's been having a pain of like a massive pain on a pain score of 10. So I noted it down in ad score as well. But ad score is 0, but pain he's been having 10. And then we get medications. So there's one medication over here which is review. And yeah, which is for review. But then I got pain medication oxytocin. He's been having for like constantly.
Yeah.
So yeah. And then
So this says he has one every 24 hours, but he's had
Means every day.
yeah.
Once
Oh,
each
once
means
every-
hourly.
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 Then that's fine then.
Yeah. Yeah, but he's on pain, which is like 3 kilos elevated. And talking about the observations, like he's quite independent, no falls risk, no pressure risk, and then neurovascular is about average total life. But everything is fine except the pain score. But then the nerves are like all altered, like radial, medial, and ulnar.
Yep.
So he doesn't have a past medical history, and he got allergic to penicillin. And then plan is the interpreter booked for 1 p.m. to get the consent for the procedure, and then AP is reviewed at similar time as well. Yeah, he can go home after the discharge, after the procedure.
Okay. So
Do you have any questions as well? Oh, one thing.
Yep.
He got a cannula on his right hand.
when was it put in?
It was on yesterday.
Yesterday? Okay.
Yeah.
Okay.
Yeah.
So you haven't done the
The
previous-
documents yet.
Okay.
And then the doctor has prescribed the CSL, but then he didn't give a time yet.
Okay.
Just, nurses fill out the time.
It's
Yeah, so that means it's charted for today and you give it when you're ready to give it.
Okay.
Yeah, so you can just say, this has been charted, but I haven't had a chance.
Okay.
Okay. Well, I can do that. And then we'll fill this out.
Yeah, I will wait for you.
Cool, alright, a few things that we should probably try and work on is having an order. Yeah, because we
Yeah.
went back and forth a little bit, I
Yeah,
think
yeah,
you're getting yourself a little bit confused.
Yeah.
But you can literally read it as you go,
Mm-hmm.
then you know. And then there was a few things that were in here that we needed to say to Alice to make sure that we follow up. So for the consent form, who did we need to contact when the interpreter turned up?
Then the overseas license.
Yeah,
No,
so
that's
you've booked
insurance.
an interpreter for today, staff need to contact the
And the
orthopedic
orthopedic
intern when they arrive.
Yeah.
Yeah, so that's something to say. Oh, when you see the interpreter call up, can you please call the orthopedic intern, because they're not on the ward at the moment, so they know to come to the ward to do the consent. And you could say the same for the APS, so do you know what APS stands for? Yeah, the acute pain service, so when the APS and, when the interpreter comes, we can call APS as well. Just say, alright, they're here, can you come to the ward to assess the patient? Yeah, otherwise it was good? How do you feel?
Nervous.
No, don't feel nervous. It's like this when you hand over patients, isn't it?
Yeah.
It's a bit tricky that one because you weren't really able to engage the patient that much
Yeah.
in the handover because it was minimal English speaking.
Mm.
But some things that you could also, like, not I'm saying this example, but if you do have a patient who doesn't have English as their first language, is when the family are there, get them to write some words in the language like pain, like good, bad, hungry,
Yeah.
and then in their language, and so you can like point to it to be like pain,
Yeah.
and that's a good way that you can determine.
Okay.
Yeah, but family aren't legally allowed to interpret for things like consent forms or anything that's like legal forms. It has to be one of our interpreters, well not our, but a interpreter who has been trained
Yeah.
in like medical terminology and all that kind of stuff, because you don't want anything to be misinterpreted. It's the same, you can't actually use a staff member of the hospital to do the translation either through consent forms. It has to be the interpreter.
Yeah. Okay.
All right. Yeah. No, you know.
So we can get like info from the family members, like
You could get collateral information
Yeah,
for sure. Yeah. It's just to fill out legal documentation has to be through the proper processes. All right. Lastly, who has Donnie Darko? But I don't think that would mean any. Do you know that film, Donnie Darko?
Never mind.
Wrong age group.
Hello. So my name is Vanessa. I'm your morning nurse. I'm just gonna do handover to my to your afternoon nurse. Is that okay for you?
Not really.
Not really. Maybe I can come back a bit later, or you can have
Yeah, we can do
outside.
outside.
Okay.
Okay.
So morning Darko.
You can say it loudly now.
Okay. So we're outside the room right now. So
Yeah.
okay. Let me just get this started. Yeah. So Donnie Darko. So Donnie is pronounced Darko, so you have to be aware about that. So Donnie just came in today to the work at 8:30. So taken with the lesser on the left wrist was fasting avocado, which might involve attendance. So we keep Donnie fasting at the moment because they might go into procedure today. But I haven't done the pre-op checklist yet because we're still waiting for the consent form. And so during the admission, Donnie declared that he drank 2 bottles of wine every day. So I put Donnie on AWS chart. And then they got a score of 5 at the moment. So I asked the doctor to prescribe diazepam and thiamine, but he hasn't been charted on the medication chart. And during the shift, they had intentionally cut themselves. So I also put Donnie on behavioral observation form, but they've been score 0 since 10 a.m. So then I notified the nurse coordinator about that. And then the nurse coordinator asked the ARN, floating ARN to stay with him. And I also made sure that Donnie would be safe and Donnie's not at immediate risk to themselves. Okay, so for Donnie's observations, extra, it was fine this morning, but it's 12:30. Donnie had a score of 1 for blood pressure, so I notified the class 15 about that, so they're aware about the blood pressure. And neurovascular observation, Donnie just had a pain 2 at rest and during movement. Donnie had strong pulse, a bit pale color, a bit cool temperature, and absent sensation and absent movement as well. Can't breathe for more than 2 seconds, nil swelling and absent nerves sensation as well. So for the medication, I gave all the morning medication and 12 o'clock medication. So everything is good. Only for 2 o'clock medication. So for Clexane, it's been good help because Donnie had an extensive bleed in the emergency, so we didn't give it. So it needs to be reviewed by the doctor tomorrow. He also has Donnie also had a cannula on the right hand. And he was score 0. He was score 0, so Donnie is not on false risk, but he's independent with the mobility. Observation is normal every 4 hourly, neurovascular every 4 hourly, and he has past medical history of depression, alcohol abuse, anxiety, and previous development of self-harm, and they also have an allergy to penicillin. And he also just got recently discharged from mental health unit. One was 1, and Kathleen was 4. So for the dressing, just get the dressing back. And just get the IV antibiotics and AWS. And we're still waiting. I informed the doctor about the capacity, about the new situation. So we're just waiting for the referral for psychiatric, okay?
Sure.
And then the consent form to be done as well. And then the maybe inform the nurse coordinator about that. Okay, yeah. And yeah, got that, Michelle?
No, all good.
That was very good. That was very thorough. That was a good one. So things that I would maybe do. So if someone ever says no, I don't want you to hand over at the bedside, which can happen with this because you probably wouldn't have wanted to hand over a lot of this information at the bedside anyway. You could say that's absolutely fine. We're still going to check the emergency equipment. You're still going to check pain bands. Yes. You're just like we just want to do a few emergency checks and then we'll leave you. You know you've got the AA, like there would have been an AAN sat with them all the time as well. But that was good. What plan do you need to follow up with?
So, this,
Psych? Yeah, so that's a psychiatric team. Yeah. But what job will you need to do?
dictate the referral and then the consent form for the.
Yes, so that would probably be what I was aiming for, is that you need to follow up with the doctors.
Yeah.
There is no consent form. Can you please write in consent this patient? That's the doctor's job to have the psych referral put in. So as long as the shift coordinator has been aware,
Yeah.
you don't know. Well done. Cool. All right. How did that feel?
Good.
Yeah.
I think it's different doing like this instead of like actually being with the patient, knowing them, and like that's much easier than.
Yeah, I know, because it's like reading off of it, like, you're more than welcome to read off the information that was in front of me, but yeah, I totally get it. You actually develop rapport when you're with your patients, and you know if you are going to be able to hand over at the bedside, you know what you want to know, what they may feel like they're a bit sensitive about. All right, so let's just quickly go on to last bit of our Okay, so next session, we're going to be covering written communication and then the ICM handovers. But any questions about anything that we've covered today?
No, I think so.
Cool. What are the 3 things that we need to check when we're going to do handover?
I need an emergency.
Yeah.
I need an emergency equipment and.
Actually, no, school. There's 2.
Consent.
Consent
And
starts with a P. Oh, yeah. Pumps. Yeah, your pumps. Yeah. Make sure you check your pumps. So there was a few times I think that someone had a back dressing, but we didn't actually check the back dressing. So yeah. But I think when it's visually in front of you, that will prompt you, especially if you've got like drains or anything like that. You're going to be like, oh, I need to make sure that the drain is working, because you'll come onto shift sometimes and it'll be debacked. Have you seen drains that are debacked? The bunny ears aren't crossing. So it's really important that you check it at the beginning of your shift, so then you don't go all shift and then you're like, oh, that's not working. Okay, perfect. All right, we're gonna wrap up there. And the next session we will bring you back. But yeah, feel free to contact me in between the 2 sessions if you have any questions. If not, I'll see you then. Thank you. Oh my God, that was so long.